All right, everyone, again, I just want to say good afternoon and thank you for joining us today. We are so happy to have you and thank you in advance for taking the time to attend our session today. Today's session is particularly timely considering that yesterday was Juneteenth, and we will have a much needed conversation about equity and what it means to provide responsive care. So today I will be speaking alongside two experts from Mathematica who I will introduce in a few minutes. So super excited about that. Thank you, So and Eli, for joining us. Next slide, please. So just to introduce myself, my name is Shannon Lee, and I am a senior program manager at PCDC, or Primary Care Development Corporation. Next slide. So for those of you that are not familiar with PCDC, we are a community development financial institution, or CDFI, and we provide capital financing, expertise, and advocacy to expand primary care access and advance health equity in the communities that need it the most. And I see a question in the chat about the slides being available after. Yes, they will. So to be clear, next slide, please, I'm sorry. To be clear, I will read the disclaimer on this slide word for word. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, CMHS, the Substance Abuse and Mental Health Services Administration, SAMHSA, or the United States Department of Health and Human Services, HHS. Next slide, please. So this is the final webinar in our Operationalizing Integration series, and I want to highlight our previous sessions. So we had mitigating burnout through integrated healthcare, collaborative care management foundations, and also system-level opportunities to improve maternal mental health. If you missed any of these webinars, I just ask that you listen to the recordings as well as check out our tip sheets. They provide practical information related to operationalizing integration. They are all linked here. And again, you will receive a copy of this presentation after the webinar. And I do want to highlight the fact that your feedback really helps inform our sessions. And I'd like to encourage you to take time at the end of this webinar to complete the evaluation survey and let us know what you're most interested in as far as future topics are concerned. We really do value your feedback and take that seriously. Next slide, please. I would also like to briefly highlight our Integration at Work webinar series tip sheets. This series was held last year, and the series provided a roadmap for behavioral and primary care collaboration. So all of these recordings and tip sheets from Integration at Work can be accessed by following the link shown on this slide. And again, you will receive a copy of this slide deck next week. So before introducing our speakers, we would like to know a little bit more about you through this poll. And if you could just let us know where you work, what your primary role is. If you don't see your setting or your role listed, feel free to drop it in the chat. Again, we'd love to know where you're joining us from. A lot of you have dropped in where you're actually from, but knowing who you are and what you do is really critical to us as we plan these sessions. We would also like to know how you would rate your current skills and comfort with understanding the root causes and various aspects of how inequities perpetuate, how you're embedding equity in healthcare and delivering responsive care. So as a reminder, again, at the end of today's session, we will transition into our half-hour open office hour so that we can answer any questions that you may have. And just can never say it enough, but today's slides and webinar recording will be made available next week for you all. Okay, so it looks like the results are in, and most of you all are from an integrated care setting, about 61%. We also have about 29% from the behavioral health setting and 10% that are in the primary care setting. So thank you so much, guys, for responding to that poll. All right, next slide, please. So next, I would like to introduce our presenters, and I will be starting with So O'Neill. So has dedicated her more than 2-decade career to reducing health disparities and promoting health equity for mothers, children, and their families, regardless of race, ethnicity, gender, religion, disability, sexual orientation, gender identity, socioeconomic status, geography, and other visible and invisible characteristics. She currently directs Mathematica's domestic health philanthropy portfolio, which has supported work for more than 50 philanthropic institutions, nonprofits, and professional associations. So partners with clients and Mathematica staff to develop and implement projects that generate evidence and translate it into action for social good. She has worked extensively with domestic and international community-based organizations and local government agencies to bring a participatory approach to strategy development and complex mixed methods research. Her experience as a first-generation immigrant and service as a Peace Corps health volunteer in Africa helped her recognize the importance of centering equity in her work and understand that systems and policy change are foundational to improving well-being. I would also like to introduce Eli Michaels. Eli is a social epidemiologist and health equity researcher. Her research focuses on measuring racism and other forms of oppression in order to understand how they get under the skin to harm health and widen health inequities. At Mathematica, Eli works to advance equity through applied technical assistance, evaluation, and research for commercial, foundation, state, and federal clients. Much of her work engages partners with lived experience to infuse equity into federal programs and practices. Eli has published in peer-reviewed journals, including the Journal of Epidemiology and Community Health, Psychoneuroendocrinology, and Health Psychology. She holds a PhD in epidemiology and a master's in public health from the University of California, Berkeley. So thank you, So and Eli, again for being here today. And with that said, let's get into today's session. And So and Eli, I turn it over to you.
Hi. Nice to see everyone here today. My name is So O'Neill, as Shannon just introduced me, and I'm a senior public health researcher at Mathematica. I appreciate you all having me today and welcome the opportunity to talk about a topic that's been the through line throughout my 2-decade career. When I began, the work was called health disparities, but as time went on, terminology shifted to health in all policies, to social determinants of health, and now health equity. And in each of these language shifts is the acknowledgement that health is influenced by multiple factors that interact in complex ways. And for me, understanding equity in healthcare is really about understanding equity and what it means in and of itself, how it shows up in our day-to-day, and the levels we can at which we can advance equity. So you'll see as part of the presentation today that in defining equity, we won't necessarily be focusing specific to healthcare, but however, when we discuss historical inequities and how we've arrived at the inequities we see today, we will use examples from healthcare service delivery. Next slide, please. So in launching into our talk for today's agenda, I'm kind of the setup person. And what I'd like to talk about is why now? Why are we having this equity discourse? You know, how has equity become such a well-worn word in our culture, in our linguistics these days? And in this section of the presentation, I'll start by talking about the current events that have brought the concept of equity to the forefront. And then in the next section of the presentation, I'd like to talk about how equity is defined, what it means, followed by a discussion about how the legacy of inequities in healthcare leading up to what we see today. And at this point, you'll notice that when we're talking about inequities, we've centered it around mainly racial inequities. But as we all know, while race is a starting point and a critical one for thinking about inequities, inequities happen along multiple other social constructed categories. So then I'll turn it over to Eli to talk about inequities through an intersectional lens. And then Shannon will close it out by talking about inequity as applied to healthcare in and of itself. And then we'll conclude with the Q&A's office hours, as Shannon mentioned. Next slide, please. My hope today is that you will all leave with an equity mindset. and lens to take forward with you, even if some of the information you might have heard before. Hopefully there'll be lots of good new nuggets for you. And I hope having the information fresh in your minds will support rich conversations going forward. Given that my objectives for today are to provide you with context for the current discourse around equity, it's also to provide an understanding of the root causes of inequities and how they're perpetuated, and really, in the end, inspire you to center equity in your ongoing discussions and work. Next slide, please. So why now? What has spurred us into recognizing and naming inequities? How has it become part of our collective consciousness? Next slide, please. A key catalyst was the national uprising around the deaths of George Floyd and Breonna Taylor due to police brutality in 2020. These events really highlighted the way that racism pervades our culture through social sectors, including health, through all social sectors. These deaths became a symbol of the oppression that Black Americans face and racism as an ingrained issue in our institutions. Next slide, please. And as the nation was reeling from these deaths, the ongoing COVID-19 pandemic really put an exclamation point on racism as an issue in health. Even though for many years we've observed racial and ethnic disparities in outcomes and made efforts to reduce these disparities, COVID brought these disparities into mainstream attention. American Indian, Alaska Natives, Black and Hispanic populations had higher rates, sometimes 2 times higher rates of COVID cases, hospitalizations, and deaths. The disproportionate burden of COVID for people of color was pretty stark. But perhaps because of where we were in the collective consciousness and because of the reverberations around George Floyd's death, we recognize racism as a key factor in these observed disparities. This recognition was then echoed by CDC Director Dr. Rochelle Walensky's declaration of racism as a public health threat. So we see this rise in collective consciousness. Next slide, please. And broader than the CDC, the federal government also released an executive order on advancing racial equity and outlined the multiple ways in which federal agencies had to embed equity more explicitly into their processes, including how, to whom funding, and social benefits were allocated. This includes equity assessments that have to be conducted within federal agencies, engagement with communities, and a call to collect more representative data. Attention to equity was being built into our very governance processes. Next slide, please. So now that we've talked about why equity now, but what is equity? What does it look like? What do people mean when they talk about it conceptually? You know, lots of people throw the terms around. How do we define it? Next slide, please. So let's begin by defining equity in words. So a lot of times we talk about equity in terms of observed outcomes, really as manifested in disparities seen between 2 different groups. But those disparities in outcomes are influenced by factors way before we observe the outcomes. So to achieve equity in outcomes means we have to embed equity in how we work and interact with the world. It means that in delivering healthcare, we make sure our structures don't favor one group over another, treats everyone fairly, and therefore doesn't cause inequities in access or services received. If our processes are equitable and everyone gets the services they need, we then get to see equities in outcomes. And what equity in outcomes looks like is the absence of differences that are avoidable, not observed, and are, we note that the absences of differences that are avoidable, and there are not differences observed, no matter the person's identity. Next slide, please. Next, you've probably all seen one version or another of this graphic to describe equity. What this picture is saying is that in making sure our policies, structures, and systems don't favor one group over another, we're not giving each person the same thing. that's labeled as equality. Instead, equity is when everyone is getting what they need to thrive. So in this case, no matter your height, you can grab the apples you need to eat. So our policies, structures, and systems allow for diversity in characteristics and identities such that everyone is able to reach their optimal health and well-being. Next slide, please. Now I'm going to show you another series of graphics to help us think about how we think about equity, or really rather the pathways to achieving equity. And the analogy here is that equity is the product of the tree, which is healthy fruits. So equity comes in the form of healthy fruits. And so how do we get to these healthy fruits? Well, in this analogy, it starts at the roots, which represents the policies and systems we create that influence our social standing and opportunities. For example, if policies exclude people who work side gigs or are self-employed from getting welfare, it's going to be that much harder for those excluded people to move ahead if they lose their job. These are the root causes that need to be upended to really achieve equity. Next slide, please. The roots then suck up the nutrients, our policies and systems, then feed into the trunks and branches of the tree, which represent the social determinants of health. So the policies and systems in the roots now determine the conditions in which people live, are born, live, learn, work, play, worship, age. These conditions are not equitably distributed and affect a wide range of health, functioning, and quality of life outcomes and risks. These are our social determinants, which dictate the quality of and use of services available to a given person. So if you live in rural conditions or have low income, you might have less access to high quality services, and ultimately your fruits will not be very healthy. And as you see, the foundation laid by the roots cascade up to the fruits, or the degree of health and well-being a person experiences. Each level of this tree represents an opportunity to advance health equity, whether it's by changing policies, whether it's improving access to social services, or improving quality of services. And quality of services include healthcare services. And Eli will expand on this concept later in the frame of intersectionality. So you have not yet seen the last of this tree. Next slide, please. So why should we care about equity? We're talking about equity. Why should we care beyond, some of the rise in collective consciousness? That some people can't reach their apples or have healthy fruits, and there are probably lots of answers to why should we care, either moral, fiscal, and otherwise. But for me, it's simple because we can do something about it. And as this quote indicates, we individually and as groups have the capacity to change the narrative and do something to advance equity, because it's something we created. We created inequities through our policies and systems. And changing it leads to better outcomes for everyone, including ourselves. So the moral impetus is that we are righting historical harms of systems humans created that do not set up certain groups of people to thrive. So next slide, please. So there's also a fiscal case, as in talking to state policy people, and that is that racial health disparities result in about 93 billion in excess medical costs and 42 billion in lost productivity in a year, according to a 2018 analysis. And in our case, that leads to 320 billion in annual healthcare spending, and 1 trillion that is expected to be spent on healthcare because inequities occur in annual healthcare spending. So next slide, please. So there's a case to be made regardless of the angle of why we need to address inequities, whether it's moral or fiscal. So how did we get here? How did we get to these inequities? Now I've presented to you, okay, here's how we define equity. Why is it risen in our collective consciousness? How did we actually get here? And in understanding how we got here and the historical harms that persist and need to be dismantled, it sets us up for talking further about the strategies to advance equity in healthcare. Next slide, please. So even though the history of inequities can really be traced back to colonization, the first time point I'd like to touch upon in terms of healthcare is the creation of the Freedmen's Medical Bureau division after slavery was abolished. In 1865, there were a lot of freed slaves living in segregated, crowded quarters without adequate food, shelter, and other necessities. And you can see one of these villages in this photo as they wait for medical care. And with these living conditions, a smallpox outbreak happened among Black communities in the fall of 1865. And with many not able to afford healthcare on their low wages, or even if they could afford healthcare, they were being denied care at hospitals. Bodies began to pile up in the streets, and cities began asking the federal government for help. Really, and part of the impetus for asking for help was because there was fear that the disease would spread to white populations in the city. So in response, the government established the Freedmen's Bureau Medical Division. Interestingly enough, it's the first government healthcare program. This is a precursor to Medicare and Medicaid. And though set up to help, it was chronically underfunded and defunded at times. Just to give a little perspective, in 1865, there were 80 doctors, 12 hospitals to treat 4 million people. And we still see this disruption today in people's care as they turn on and off of eligibility for health insurance. And the underfunding of healthcare for certain populations, we still see this today. Some estimate that the Indian Health Services 2022 allocated budget is less than half of what patients need in the service. For example, IHS receives $7 billion in funding versus the estimated $51 billion needed to provide for that population. Next slide, please. And with Black populations having poorer health, instead of concluding that more care and hospitals were needed for Black Americans, the scientific and medical community concluded something completely different. They concluded that, and I'm quoting from Frederick L. Hoffman here, who you see pictured, that excessive mortality rates in African Americans were due not in the conditions of life, but in race traits and tendencies. Some medical professionals today continue to incorrectly believe that there are genetic differences between races that cause differences in health outcomes. You might have heard this pretty often, that some health professionals falsely believe that higher rates of hypertension in the Black population is due to genetic trait that causes Black Americans to retain more sodium in their blood. That is not true. So you can see how some of these narratives still persist. Slide 25. Next slide, please. As time went on through the 1800s and 1950s, the systems and narratives did not get much more equitable. In fact, the healthcare system further eroded trust among people of color. And a famous, or should I say infamous, example of the perpetuation of the lack of valuation of Black lives is the Tuskegee syphilis study. This study promised Black men infected with syphilis free medical care if they participated in the study. But unbeknownst to them, the US Public Health Service and CDC wanted to understand the natural progression of syphilis. So the participating Black men were given medical care, but not penicillin at any point to cure them. And with these types of instances, we can understand the distrust that Black Americans might have for the medical system today, because this is one of many stories. There's a book called Medical Apartheid that lists a lot of these egregious harms that have been done. In 1997, President Clinton publicly apologized to families of the victims. But as we'll see, it didn't get that much better yet. And that's why we still need to do something. So next slide, please. So the arrival of Medicaid in 1965 seemed like it would right some of the systemic issues excluding people of color from care. But unfortunately, because of the way it was structured, it actually reinforced their exclusion initially. Medicaid eligibility was tied to welfare eligibility. So a lot of people of color were not eligible for Medicaid coverage because they tended to work side gigs and not have formal employment. So they weren't eligible for welfare, which meant they weren't eligible for Medicaid. So welfare reform in the 1990s finally de-linked Medicaid eligibility from welfare eligibility with unintended consequences. It was supposed to help kind of right some of the exclusions that were happening because it was linked to welfare eligibility. Unfortunately, the delinking of eligibility for these programs in 1996 generally served actually to exacerbate inequities in some states because it allowed those states to avoid expanding Medicaid eligibility, even as welfare eligibility changed to keep up with inflation. And these mainly impacted communities at the margins of wealth who didn't qualify for Medicaid at kind of the lower levels of federal poverty that were the cutoffs, but were not in employment that got employer insurance or could not afford insurance. So 10 states today still have not expanded Medicaid. And these states account for 92% of the coverage gap among adults in the US. Most of those falling to the coverage gap, as you may have guessed, are people of color. Next slide, please. Now, as we move from inequities perpetuated by policy, there are those existing in our infrastructure still today. Now, we still see inequitable distribution of healthcare resources across the country. In this picture, you see the darker blue counties have increasing number of healthcare deserts, and the darkest blue having 6 or more healthcare deserts. Given that this map is more blue than light teal, we have about 80% of the country without access to adequate healthcare. And according to GoodRx Health that developed this map, when they say adequate healthcare, they're considering pharmacy, primary care, hospital, trauma centers, and low-cost health center access. And as you can see, the concentration of healthcare deserts are in Alaska, the South, and the Midwest. Next slide, please. Now that we've talked about policy and infrastructure, let's talk about healthcare delivery and inequities that still exist here. Much of the inequities in healthcare delivery have to do with implicit bias in organizations and individuals. And how that shows up is that various groups do not have equitable access to care. In a 2016 article, you'll see a quote here from Ashish Jha. He highlights one of these data points to illustrate this. If you're having a heart attack, there are very standard protocols. If you're African American, you're less likely to get those protocols, even with the same health insurance, even with the same presentation. The consequences of these inequities in care delivery are hefty. The article goes on to estimate that low quality care leads to 260 premature deaths among Black people daily, translating to 94,990 premature deaths annually. That means that about 27% of all deaths in Black populations might have been prevented with better and more equitable quality of care. So now that we've talked about the legacy of how we got here and the inequities that remain in the health system, I'm now going to turn it over to Eli to introduce even more complexity into how we understand inequities and how it presents for any single individual.
Thank you. Can everyone hear me okay? Good. Okay. Thank you so much, for laying the foundation of equity and for outlining some of the historical roots of the present day inequities in health and healthcare. My name is Eli, and I'm a health equity researcher at Mathematica, and I'm really honored to be able to speak with you today and expand upon this foundation that So has laid out for all of us. Next slide, please. Okay, so as so mentioned, many of the slides so far have highlighted racial inequities, and that's often the starting point because we see such persistent and striking racial injustices in this country that manifest in health inequities. But now I'd like to take some time to expand the conversation to focus on inequities experienced due to a multitude of other socially constructed categories. So beyond race and ethnicity, we see inequities in healthcare and health outcomes for communities experiencing poverty, people who are immigrants, who identify as LGBTQIA or more, people with disabilities, and people living in rural areas. So I'm going to begin by showing you some data to illustrate these inequities, and then I'll introduce the concept of intersectionality to help us understand and unpack them. Next slide, please. Thank you. Here are some findings from two studies. So the first figure on the left shows age trajectories of allostatic load. Allostatic load is a marker of cumulative systemic dysregulation that predicts multiple chronic health conditions. You can think of it as the wear and tear on your body, which increases naturally with age, but it can be accelerated due to chronic stress. So I'll orient you to the figure. On the y-axis or the vertical axis, you see the predicted probability of having an elevated allostatic load or more wear and tear on the body. And on the x-axis, you see age. The 4 lines on the figure show age trajectories at the intersections of race and gender for white men and women in the squares and Black men and women in the circles. And what we can see here is that Black women, shown in the hollow circle in the top line of the graph, have higher allostatic load at younger ages compared to Black men, white women, and white men. And these findings have been reproduced over multiple markers of accelerated aging and are believed to result from the repeated anticipation of and coping with the unique experiences of gendered racism experienced specifically among Black women. So you see that accelerated aging happening. The text box to the right summarizes findings from a study examining smoking during pregnancy at the intersections of race and sexual identity. So this study found, and I'll kind of summarize, they found that smoking during pregnancy was more prevalent among pregnant people who identified as LGBTQIA compared to heterosexual pregnant people. But then they overlaid their analysis with race and ethnicity. And what they found was that the gaps between LGBTQIA and heterosexual pregnant people were actually wider among Latina people compared to white people. And so there's this intersection happening. And one interpretation of these findings is that stress may compound for people experiencing discrimination on the basis of their race and their sexual or gender identity. And smoking during pregnancy or any time can be used as a coping response to deal with amplified levels of stress. Next slide, please. Now taking a look at healthcare and looking at the international context, these Venn diagrams are based on data from Nepal, and they show us how intersectionality plays out in another setting. So they illustrate the coverage of maternal and newborn health for groups with different marginalized identities. Ideally, we'd see 100% coverage for everyone, regardless of their identity or social position, but that's not what we see. What we see here is diminished coverage for people with different social identities, which compounds as the number of marginalized identities increases. So for example, taking a look at the diagram on the left, we see that 79% of people living in poverty had 4 antenatal care visits. And that proportion drops down to 55% when they also have low levels of literacy, and down to only 48% in the center of the Venn diagram when they're also a member of a disadvantaged ethnicity. And we see this intersectional marginalization compounding even more for postnatal care visits within 48 hours of delivery on the right. These examples have shown how healthcare access and use, health, and healthy aging are patterned by race, gender, sexual orientation or identity, and their interactions layered on top of each other. And we often see health outcomes and inequities exacerbated for people who hold multiple marginalized identities. So how can we make sense of these findings? What is going on here? We'll now introduce the concept of intersectionality to help us understand the root causes and the drivers of the patterns that I've just showed you. Next slide, please. Intersectionality is a framework that people talk about a lot and increasingly, and you may have heard before. And I want to take a moment to really unpack it for all of us. So at its core, intersectionality is a framework that was developed by Black feminist activists and legal scholars. And it was used to describe how people's lived experiences, well-being, and health are shaped by multiple interlocking systems of power, privilege, and oppression. So taking a look at this diagram here, we see the person in the middle. And this person, like all of us, can identify themselves based on their race, their gender, sexual orientation, education level, age, and another number of other socially constructed categories. We are all layered and complex people with multiple identities. Common conversations about intersectionality stop there. However, at its core, intersectionality is about zooming out to see the structural forces at play. And that's really our goal for today, is to take that step back and look at the bigger picture. So continuing to look at this image, we see how this person in the middle has their own individual level identities in the small Black text, but how those experiences are shaped by broader social systems. So the way this person experiences their race is shaped by racism. And you can see that with the red lettering pointing into race in the upper left. The way this person experiences their gender is shaped by sexism. The way they experience their sexuality is shaped by heterosexism. And this is true whether they occupy a privileged or a marginalized identity. The experience of being Black is shaped by racism, but the experience of being white is also shaped by racism. It affects everyone, these systems. And all of these experiences intersect and compound, as we saw in those previous examples. So this framework helps us really see how having a marginalized race or gender or sexuality is not a risk factor for poor health. It's racism, sexism, heterosexism, and all of the other isms that are the risk factors. And they shape opportunities, experiences, and ultimately health for people based on their identities. So now let's take a return back to our tree to unpack how this occurs at different levels. Next slide, please. So our tree analogy that So introduced helped us understand how health is influenced at different levels, from structural to social to healthcare. And we now return to the tree and examine how intersectionality shows up at each of these levels. So we're layering in another layer here to think about how intersectionality shows up. And we're also going to add a level, the soil, which we'll soon introduce. For the purpose of the conversation, and to demonstrate how intersectionality shows up, we're going to focus on three forms of oppression: racism, sexism, and heterosexism. However, this is an oversimplification of intersectionality and how it operates. Systems of oppression not pictured here include, but are not limited to, classism, colonialism, ethnocentrism, ageism, ableism, fat phobia, Christocentrism, xenophobia, colorism, and cisgenderism. Next slide, please. We'll start with the soil. The soil represents the cultural determinants of health, our shared values and belief systems. It creates the foundation and the nourishment in which our tree grows. Racism, sexism, and heterosexism, and these other cultural systems are all rooted in the soil. These ideologies and values shape perceptions about which members of society are most valued and whose lives are most important and worth protecting and investing in. Cultural determinants of health are often made visible in the media. For example, media representations and beauty standards reinforce ideologies that value white, cisgender, able-bodied, young, thin people above others. And by signaling whose lives are most valuable, the soil affects individual and collective decision-making, shaping how our social structures and institutions operate, including the policies passed and the infrastructures built. Next slide. Rooted in the soil then are the or the structural determinants of health, the social, economic, and political policies and practices that determine the distribution of important resources and opportunities. What intersectionality allows us to do is see how these multiple systems of structural oppression overlap and reinforce each other through policies to concentrate power among the most privileged groups in society and exclude those with multiple marginalized identities from resources and opportunities. We can apply intersectionality to the example So gave a few minutes ago about Medicare and welfare policy in the beginning of the talk, to see how labor policy and healthcare policy were shaped by racism and capitalism to exclude poor people and people of color from having access to consistent, reliable, and quality healthcare. Next slide, please. Turning to the trunk and branches of our tree, intersectionality allows us to see how health promoting social determinants of health accumulate to benefit health for privileged members of society. So the more forms of privilege one experiences, the more healthy social determinants they will have access to. More resourced schools, safe neighborhoods, safe workplaces, and so forth. And at the same time, health harming social determinants of health can cluster and compound risk for those with multiple marginalized identities. And one way to make this really concrete is to think about how this plays out in neighborhoods. A few minutes ago, So showed a map of the distribution of healthcare resources across the United States. And because of the roots, because of policies, zoning decisions, and disinvestment, neighborhoods that are home to communities of color, immigrant communities, and those with lower levels of income often have less access to healthcare, or what we call health deserts or care deserts. But in addition to low healthcare access, these same communities often have lower food access, sometimes called food deserts, as well as other social and environmental risk factors like poor housing quality, over policing, and toxic producing facilities, and fewer jobs. And these social determinants cluster and compound and intersect to shape risk for these communities facing multiple forms of marginalization. Next slide, please. Moving on up our tree to the leaves, we see that the quality and use of health services, we see that intersectional forms of discrimination and stigma can shape the healthcare experiences of those with different combinations of social identities. So, for example, Black women experience gendered racism when engaging in with healthcare providers and systems. And these experiences can multiply to exacerbate health inequities, such as the accelerated aging I showed on that graph before. Another example is how different forms of stigma can intersect to undermine health and healthcare experiences for people living with HIV who are also members of marginalized racial or ethnic groups, are part of the LGBTQIA community, and or engage in IV drug use or sex work. Next slide, please. So here's our full tree, and you can see the fruits at the top of the tree. And we've now described how intersectional forms of inequity at each of these levels, from the soil, the roots, the trunk, and the branches and the leaves, can culminate to produce health inequities. If we could advance equity instead of inequities, if we could advance equity at each level of the tree and work at these different levels, the result would be health equity, or the highest level of health and well-being for all people, regardless of their race, gender, socioeconomic position, education level, sexual orientation or identity, or other categories. But what would it take to get there? How could we infuse equity into our process so that we could achieve equity in our outcomes, like So laid out for us in the beginning of the talk? Next slide, please. This slide at a very high level describes possible interventions to advance equity at all of the levels that I've just described, starting with the soil and making our way up to the leaves. I'll touch very briefly on the lower levels of the tree and we'll focus mostly on the leaves. But briefly, attending to intersectionality in the soil will require cultural shifts to change our hearts and minds. And we'll return to this at the end of today's talk. Moving into the roots, Policymakers must ensure that policies center intersectionality by addressing multiple systems of inequity at the same time. Policies and systems that perpetuate inequities must be redesigned or replaced in order to redistribute power, wealth, and resources equitably. Then policies that redistribute wealth and power will in turn shape the distribution of the social determinants of health in the root, in the trunk, and the branches of the tree to ensure timely and needed resources are available to everyone. And while interventions at all of these levels are needed to advance equity, we will focus on the leaves or the quality and use of health services. Whole person-centered service delivery means tailoring the content, composition, and coordination of resources to provide non-discriminatory, high-quality services that are rooted in an understanding of intersectionality. So I'll begin to describe what this might look like, and Shannon will build on that toward the end of the talk. Next slide, please. So the quality and use of health services depends on the workforce, the processes of care, the infrastructure of the system, and the data that support all of it. In terms of workforce, ensuring diversity of identities and types of services provided can really affect the experience that patients have. We know that trust in the healthcare systems and in providers is a critical factor in whether people seek care. And studies show that race and gender concordance between patients and providers leads to better outcomes. So when patients have the same race as their provider, we see better outcomes, and the same is true for gender. But thinking about all the layers of intersectionality, we know that diversifying the healthcare workforce, not just in terms of race and gender, but also sexual orientation and identity, disability status, language, and other factors is an important step toward ensuring providers share lived experiences with their patients, which can improve health. But training in intersectionality and structural competency, like we're doing today, can also help providers from all kinds of backgrounds provide more compassionate and holistic care. In terms of infrastructure, we know that the social determinants of health can intersect. So people face barriers related to transportation, work constraints, food insecurity, language, and disability. So designing infrastructure and technologies that attend to these intersectional barriers can help to advance equity. For example, offering extended hours, satellite locations, or a traveling workforce in less affluent neighborhoods can help people access and use care. Attention to intersectionality can also improve the process of care. So understanding how these intersectional factors shape people's lived experiences, their health behaviors, like we saw in the smoking example, and access to care can help providers tailor services to provide affirming care for all patients. Engaging patient navigators to coordinate care can help meet individuals' healthcare needs. And finally, having cross-sectoral data is very important in the provision of care to understand patient circumstances that influence their health and adherence to healthcare recommendations. So that's where partnering and coordinating with community-based organizations is so important. They have a plethora of data and knowledge, real knowledge of their communities that can help see the fuller picture of health and healthcare. Next slide, please. So finally, I'd like to end by going back to that harder question of how we can address the soil and the cultural determinants of health. Enriching the soil with anti-racist, anti-patriarchal, anti-ableist, and other affirming ideologies is what is needed to create a healthy and fertile home for the tree to grow. We know that shifting culture might seem like a daunting task, but it starts with each of us examining and reflecting on our own identities, our privileges, our implicit biases, and how all of this translates into how we treat each other, how we advocate in our communities and our organizations, and the decisions that we make. So, for example, assuming that people without a certain degree or title cannot be an expert, by doing that, we are doing them a disservice and devaluing their experience. And when we accept pluralism in perspectives and ways of being and the complexity of how things interact in the world, we can understand that what works for one person might not work for another, and we can work together with patients and partners to tailor treatment and strategies. And once we recognize this complexity, we can also begin to understand that we each play only one part in this very complicated system. To advance equity, we must collaborate with each other and with other social sectors to really tackle the root causes of health inequities. This trans-organizational thinking is necessary to break out of our silos and how we work and help us enter into systems thinking, given the complex, intertwined, and sometimes tangled factors that influence health. So we hope that today's conversation helped to demystify the concept of intersectionality, enriched the soil, and planted the seed for equity for all of you to bring into your practice and work. Thank you so much for your time and attention, and we look forward to the office hours.
Next slide, please. So and Eli shared some valuable information that really provided some context to the historical roots of inequities, why equity and intersectionality should matter to us, and the power that we hold as far as impacting change. Next, I want to build on that foundation and discuss ways in which you can assess the complex needs of your patients or your clients and right-size your integration services. Next slide, please. So earlier in the presentation, we saw a graphic that spoke to equality and equity, but we've heard a lot of information since then. So I really want to level set before we begin our conversation around care that is responsive and highlight the fact that in reflecting on equality, it's critical to understand that providing equal treatment means that every client or patient gets the same type of care, regardless of whether it's needed or if it's right for them. However, whenever you're providing care that is equitable, each person gets the treatment that's right for them. This allows for your clients, as Eli mentioned, or your patients to attain the highest level of health that's possible, regardless of their cultural, their demographic, or their socioeconomic status. Ultimately, really seeking to understand the strengths of your patients as well as their circumstances, including the barriers that they face on a daily basis, will be critical for your organization as you look to right-size care. Next slide, please. So next, I want to touch on responsive care and what that means. Whenever you're providing responsive care, you are being intentional. You are also being consistent. And providers, as well as organizations, must strive to see, respect, and celebrate the aspects that make their patients, their clients, and even their teams unique. So whenever you're acknowledging the differences in the intersectionality of those that you treat, as well as those who support your organization, so your teams, you will really pave the way for positive health outcomes, for retention, and also for organizational success and sustainability. Next slide, please. So being intentional and ensuring that the care that your organization provides is responsive can take place at the point of care or the patient level, as well as at the organizational level. So at the point of care, making an effort to listen to understand versus listening to respond, that's critical. And it's critical that the care that you provide is patient-centered, that it's safe, it's timely, efficient, effective, and also equitable. So by treating each person that you come in contact with as an individual, while also recognizing your personal biases, this will help you be present in the moment and ultimately impact care and health outcomes. And then also in thinking about being intentional and responsive on the organizational level. So this can look like evaluating your integrated care models and determining which is the most ideal for your organization, or identifying ways that you can optimize your organizational structure. So being responsive also means that you're striving to foster collaboration pathways between interdisciplinary teams, and you're continually assessing the needs of your patients and your community while ensuring that your staff have a voice. So being responsive is multifaceted, right? But it can lead to right-sizing your integration services for positive health outcomes, like I said, retention, and that long-term organizational sustainability that we're all seeking. So we've talked a lot about what equity, and responsive care are. So I do want to shift gears a little bit and discuss how you can be responsive. Next slide, please. So a significant method for identifying ways in which you can be responsive, both at the patient level as well as the organizational level, is in analyzing patient data. This can be used to determine what your patient or your organization needs before anyone tells you. This will also provide insight into which of your patients may need additional supports. And in saying that, data can also help you as you look to provide more complete integrated services. It's important that as you dive into patient data, that you're reviewing and you're analyzing aggregated reports from your payers, from electronic health records, and any population health analytic tools that you're using, because they can help you determine, like I said, which of your patients are at a higher risk for overutilization of care, as well as those who may be more likely to be admitted to the hospital. So you're kind of doing that risk stratification so that you're able to better impact the lives of your patients and improve health outcomes. I also want to point out that information from regional health exchanges can also be useful as you look to provide care that's responsive. And whenever it's combined, this information could help you as you reflect on the model of integrated care that you choose. And it could also support recommendations that are made to leadership about changing your model or even growing your interdisciplinary team to better support your patients and your organization. I also want to note that it's really important to use the information that you learn strategically. And if you're in a position to build or optimize your integrated care offerings, to really think through what works best for your patients and your organization. Ask and answer the question of whether you can realistically offer any new services to a reasonable percentage of your patients. And if you can't, think about identifying ways in which you can be intentional about building partnerships and also building that referral network. Next slide, please. So on the previous slide, I showed kind of examples of static and dynamic risk factors that spoke to social determinants of health. And I think it's really important to also provide examples of tools that you can use to capture data when it comes to this. And these are specific to social determinants and drivers of health. So the first tool that I want to share with you, many of you may be familiar with this, but it's the protocol for responding to and assessing patients' assets, risks, and experiences. This is known as the PREPARE tool, and it's nationally recognized and standardized as a patient social risk assessment tool. It's evidence-based, it's also stakeholder-driven. And on a patient level, this particular tool allows care teams to evaluate specific patient needs and respond through shared decision-making, priority setting, and appropriate interventions. On an organizational level, this tool would provide potentially a set of data that could better inform and advocate for risk adjustment and resource allocation to support care coordination. Next slide. So briefly, I just want to highlight the American Academy of Family Physician Social Determinants of Health screening tool. This is available in short and long form. Next slide, please. And then also sharing with you the Centers for Medicare and Medicaid Services Accountable Health Communities 10-question health-related social needs screening tool. This can be self-administered, and it really helps assess patients' needs in the domains of housing instability, food insecurity, transportation, and utility health. So really, as you're reflecting on patient data, as well as the tools that could aid in collection, it's important that you remember that this is a team effort, that everyone on your team should be involved in that data collection, the screening, and the follow-up as you are integrating services into your organization. Next slide, please. So really, to improve responsiveness as well as continuity of care, it's important that in your EMR or your electronic medical record system that you're capturing services, whether they are billable or not. And in speaking of social determinants of health, I really wanted to mention Z codes, which are codes that represent subsets of diagnosis codes that describe factors that influence health status. So here on this slide, you'll see Z codes Z55 through 65. They identify social determinants of health and describe conditions such as poverty, homelessness, abuse, or neglect. And typically payers, deny these codes because they are classified in ICD-10 as unacceptable principal diagnosis codes. And when I say deny, I mean that you're not reimbursed for it, but I wouldn't let the fact that you are not reimbursed for using these codes deter you from using them. because they can help you track and understand your patient population. They can also help with risk stratification, as well as whenever you're mapping out workflows. They can also support requests to leadership related to enhancing your partnerships and your service offerings, and even as far as expanding your care team. Next slide, please. So shifting away from data and patient screenings, I do want to highlight the patient voice, right? So listening to your patients is key, and it's key to the success of being responsive as well as your integration efforts as a whole. So I encourage you to adopt the mindset of continuing to assess patient needs over time, because this ensures that you're putting your patients first and you're making sure that they have a seat at the table. So focus groups and patient and family advisory councils are best practice for ensuring that you're not only listening to your patients, but you're capturing that information and you're using that information to better support them as well as your organization. Next slide, please. So acknowledging your patients and seeking to understand their situations, their circumstances, and their needs can really provide insight into necessary resources, as well as help you identify gaps and update workflows, processes, and procedures. This can also help as you develop culturally responsive educational materials and can help support you in determining the need for expanding services, or as you develop partnerships with other community-based organizations. I think it's really important that you know that by listening to your patients, you can really ensure that the services that you're providing are connected to the needs of the population that you're serving. Next slide, please. I also encourage you to think of your organization as a part of the fabric of your community, where you want to ensure that the care that you're providing is culturally responsive and appropriate for the community at large. I was recently at the California Primary Care Association conference, where it was recommended that we conduct needs assessments annually, community needs assessments annually versus every few years, because the needs of your communities are changing very rapidly. So conducting more frequent assessments really allows you to solidify your status as an organization that is not only responsive, but as one that cares. So these assessments can also help you in providing more complete services. They could also highlight opportunities to provide care in alternate settings. And it's really important to use your community to help you to plan strategically and seize partnership opportunities to build a robust referral network if that's the path that you choose. Next slide, please. So I also want to mention your care team, right? And really using the insights of your care team, because they're priceless, and their relationships with your patients and your community are essential to informing the type of care that you provide. So really consider maximizing their insights and ask that they be represented at operational, clinical, and quality improvement meetings. Doing this will increase communication, it will increase teamwork, and it could also serve as a vehicle to increase their buy-in when it comes to the work that they're doing, that frontline work that they're doing every day. Next slide, please. So I do want to highlight a few additional factors for you to consider that could impact responsiveness, the first being documentation requirements. So whenever you're providing care and you're creating programs that are responsive to the needs of your patient and your organization, really consider, when do you document? What specifically do you need to capture? Who can capture the necessary information, and how this information can be captured in a way that informs the next reviewer? Consider your EMR system and your current workflows and policies. Do they support the addition of any new services, if that's the path that you choose, that require changes in how you currently document? Another factor to consider is billing and reimbursement. So knowing where you stand financially and identifying opportunities for increased revenue. So this will help position you if you decide to add service offerings so that they're actually supporting the patient populations that you serve. It's really key to know your financial health of your organization before making any decisions associated with responsiveness. Also thinking about, the demand for virtual care delivery. This has significantly increased since the end of the PHE, or the public health emergency, and many organizations had to adapt on the fly to ensure that you were being responsive to your patients' needs related to telehealth. So really documenting those lessons learned when standing up telehealth, and use that information in the continued use of virtual care delivery, but be mindful of any changes to policy requirements, like related to modality requirements, that can impact your organization. Next slide, please. And so finally, I'd like to mention, the end of the public health emergency. We all kind of adapted very quickly whenever the PHE went into effect, but as that's ending and there's this overall unwinding of Medicaid taking place, this definitely will, in fact, impact responsiveness. So I understand that each state is different, and we have people from all across the country on this call today, but really dig deep into whether there are flexibilities that are ending that may negatively impact your organization from that financial perspective. And also consider if there are changes that have been made permanent that could have a positive impact on your organization, that may provide opportunities to increase revenue, or, make those service offerings permanent that you implemented during the PHE. And then also, as far as the unwinding is concerned, understand that your patients may fall off and on eligibility, and consider not only how this impacts your patients, but your organization. I encourage you to use these changes as a catalyst to review and update your current policies, processes, and procedures, so that you're able to maximize your level of responsiveness. Next slide, please. So kind of to wrap everything up, I just want to highlight that, providers and organizations are charged with a lot, right? With providing care that is safe, timely, efficient, effective, equitable, and patient-centered, and in prioritizing not only an awareness of equity, but an intentional commitment to providing equitable and responsive care. I think it's possible that you could see, an improvement in patient care outcomes. You could potentially see an increased buy-in from your care team. You may identify policies that you can update to better support your organization, or, even update your service offerings, your integrated care model. You could expand your multidisciplinary team, or really seize opportunities to build and improve community partnerships that result in you providing the care that not only your patients, but your community needs. Next slide, please. All right, so we've wrapped up the content portion of our session. We've gone a little bit over, so I want to move very quickly and shift into the poll. Thank you, team, for doing that. So if you could just answer the questions that are here, or the question that is here. And I have not had a chance to look at the chat to see what questions we may have, but I will be doing that now. And we will begin our Q&A session. Okay, I think the poll has wrapped up, or is in the process of wrapping up. So let's get into some questions. Can you go to the next slide, please? Thank you. Oh, yeah, the office hours slide. Thank you. Thank you all for the feedback that you've been dropping in the chat. I see one question. And I'm going back and seeing if there are any other questions, or if it's just the one. Okay, it looks like we have the one question from Diana. If concordant relationships increase utilization of healthcare services in marginalized and minority communities, how do we encourage or promote these professions in those communities?
Thanks, Diana. That's such an important question. I'll start, and then my colleagues can jump in. I think what's so helpful about the tree is it allows us to see how factors at multiple levels not only affect health, but also economic outcomes, educational trajectories, and so forth. So I think that it really does start with the roots and the policies and opportunities that are in place for education and training in STEM, in medicine, in healthcare in general. And so looking at affirmative action and other reparative policies that can ensure greater access to those pipelines and support for folks in those pipelines is an important starting place. I'm curious if my colleagues have other thoughts.
Yeah, I mean, I think that's right. I also think that, you know, I I think there are encouraging those pipelines as individuals. What can you do? I always hear that as a question, like if you offer internships or whatnot or to folks that are in populations that have been marginalized or historically marginalized and deprioritized, really. That's kind of the way individually you help. And then I don't mean to be trite at all, but it's also how you vote, right? Because those are the systemic issues. And we all have a voice in doing that, as Eli said, in changing hearts and minds. And I think this gets at the second question here as well from Diana, which is that, structural and social determinants of health feel huge to take on by yourself, but there are little things you can start to do when you start collaborating, you start changing your mindset, start having these open conversations like we're having today. That starts to shift things for in the culture and discourse. And now is the time. It's part of our collective consciousness, as we had mentioned.
Thank you both. So there is an additional question. It's a two-part question, and I will start with the first part. So how do you stay encouraged when implementing initiatives targeting structural determinants of health and social determinants of health when previous legislative policies have been against health equity?
So I think So already started to touch on that. And then just to build on it, I think, like So said, changing structures and changing the soil and the roots can seem really daunting, and we can all do our part by voting and by advocating and by changing our hearts and minds one step at a time. But I think there's also work to be done at all levels of the tree, and one level that we all have influences in our organizations. And so having an eye for equity and thinking about intersectionality and looking at the level of how organizations and systems, whether that be a healthcare system or a research organization in our case, how are kind of the small p policies operating, those kind of formal and informal practices that happen at the organizational level, how are they operating and what can be done and how can we advocate within those spaces to advance equity with this eye for intersectionality. So looking around not only at racial injustice, but how that overlays with other forms of injustice and then using our voices.
And I would say that I think part of what Eli and Shannon both alluded to in terms of community voice and community power as a means for helping address those structural and social determinants of health is a really key point, is that, as you're working in your organizations, how you engage with community, how you work with coalitions that may be forwarding some of the agendas. Is there evidence you can provide? Is there partnership that you can engage in that would help address some of these structural and social determinants of health beyond your quality of care that you are doing already?
And I think for me, to stay encouraged, being very passionate about the conversation that we've had today, it's really important for me to remind myself that change doesn't always happen overnight, that it takes time. And when I am discouraged, I tell myself that my voice does matter, that my input will have an impact, I think. So sometimes you have to have that positive self-talk because it can be very discouraging. And I know that's kind of on a more insight level versus, policy but I think it's really important. And I think also thinking about the fact that in having these conversations, sometimes you have to get comfortable with being uncomfortable and knowing that while change doesn't happen overnight, it's not an easy process for a lot of people to come to the table and have conversations related to the subject matter that we discussed today. So that's just kind of something for me. And the second part of that question, and you may have answered it, what are steps and tools to combat policies that limit services and opportunities to further improve health? So just kind of trying to think through before I just like start talking. Eli, I see you came off of mute.
I was gonna say, so you can start with this one.
Yeah.
I mean, this is that big question of how do we shift policies from all of our various vantage points, which might be in the policy space and might be more at the level of providing care. So I'm curious if my colleagues want to start.
Yeah, and I had a little distracting moment. I was looking at Felicia Marie's question.
Oh, okay.
So
No, it's no problem. I think it really depends on, you know, what setting you're in and where you are as far as the steps and tools that you can use to combat policies. I think it's really important to know the policies of your state so that you can kind of develop, you know, like workarounds where you're able to provide that care, provide those services, and make the most impact on your population. But I think, you know, with having, you know, kind of like been in this for a very long time, just understanding that knowledge is power. And I think that's where a lot of people miss out because, you know, they miss the bulletins, they miss the announcements, they miss, you know, the bill reviews, you know, all of these different things, but really making sure that your voice is heard, utilizing those public comment periods to share, because like I said earlier, your voice does matter, your input does have an impact. So that's kind of from a different perspective, a way to think about it. And then I see Felicia Marie's question. Would you agree that a factor of giving proper service delivery is staffing, training, and education of staff and deeply ingrained systemic racism or sexism towards BIPOC staff? Basically, if our sites are understaffed and retention is non-existent, how then can you provide good person-centered care when the leadership is hesitant to embrace health equity? Non-consistent staffing and big turnover has a direct impact on clients, especially with those with IDD and DD and other mental health conditions.
yeah,
And yeah, I agree with that. So I'll let you go. We're all nodding our heads like as I'm reading.
yeah, and I think that this is one of those things where it does take time. And I agree with all of this, that part of it is about service delivery, is this the staffing and the systemic kind of racism, sexism towards BIPOC and you know, female staff in particular, female gendered staff in particular. But I think part of this is that we all are kind of trying to uproot and upend all of this in our organizations. And part of it is starting with valuation, like understanding that everybody's voice has value and starting to demonstrate that to leadership. And sometimes it does require really hard conversations, like uncomfortable conversations, and making explicit what's been implicit for so long in ways that will work and be heard. Now, sometimes that means seeding conversations. I often do this where I see little hints, nuggets here and there with lots of different people in the organization. And then we plan kind of a bigger conversation around it and people are more open to having those conversations because I've done a little bit of seeding. So, you know, it really depends on what's going to work in your organization. But I think that you would be best equipped to really be able to understand how to manage power and power dynamics, because that's what we're talking about here.
I agree. And I think, you know, I think workforce is an issue that's just going on nationally, just issues with retention and hiring, staff feeling overworked, you know, burned out. So it's really tough to come to work every day and support patients whenever you have so much to deal with in your personal life, right? So I think it's helpful to kind of think through like getting that leadership buy-in, whether or not it makes sense to do employee resource groups or affinity groups where the staff that you do have are having those conversations, and you can share that information on some level with leadership so that they know the factors that are impacting patients. Like I said, it's really hard to deliver good care when you're burdened by the world around you. Which often happens with, you know, the things that we see daily on the news and even in our own personal lives. So really tapping into that as well.
I want to just add something that a question 2 questions ago about how can we as providers kind of advocate for policy, and how do we address the roots when the roots are so big and they're so fundamental, and that might not be the level at which we're working. And one piece that I wanted to add is that no matter what level, whatever level we're working at, I think having an understanding and a view of the tree can lead to a fuller picture and more compassionate and better care. So if you only see the fruit, you only see the individual patient maybe who's experiencing homelessness without zooming out to the roots of why that might be happening, that tells one story. But by having this kind of structural and multi-leveled understanding of the structural and cultural and social factors that lead to something like homelessness, whether that be gentrification and displacement or the inaffordability of housing, for example, where I live in the Bay Area, that can really contextualize the healthcare experiences and the health of the people that we aim to serve. And I think that understanding alone does, we're talking about shifting hearts and minds. That doesn't just mean implicit bias. That means structural competency. And that's really what we're talking about here. So I just wanted to add that just having this understanding is doing the work. And then when the opportunities to advocate for policy change present, then that's great. But the knowledge is power, as Shannon said.
Okay, and I have one more question or conversation point. So understanding that the patient provider, you know, relationship can improve outcomes dramatically, but with the huge issues in hiring staff these days, let alone enough diversity in staff to match a given patient population, what else can we do? Have you seen any particular successes with other methods like implicit bias or cultural understanding training, specific policies or workflows? And I encourage anyone who is on the line still to drop in the chat if there's anything that you've seen that's been successful for your organization. I really want to encourage you to kind of like drop that in as well. I know sometimes we're on another side of the table, but I definitely think having those conversations within your organization, understanding that, like I said earlier, you have to be comfortable with being uncomfortable. It is not easy. I've done it myself where I've been in a work group where we've tried to kind of like put together and build out these initiatives, and the conversations are hard. And you may get to a point with your group where you all are able to trust each other and have these conversations, but then whenever it comes to leadership, is a much more difficult conversation. The only thing I can say is don't give up, just kind of chip away over time. And then as you onboard new staff, create a plan for them so that they're walking into your organization feeling like they can trust those around them, that they can have those conversations, that they know where their leadership stands. And we had someone drop in the chat, trauma-informed care implementation and transformation. Thank you for that. So if anyone else has any ideas or suggestions, feel free to drop those in the chat as well. That's really important and critical, like Eli said. And so do you have anything else you'd like to add?
Yeah, I'm trying to think through if there are any particular implicit bias or other types of training that we have seen as successful. I think anything helps, to
Right.
be honest, anything, because what really helps is beginning that discussion and having that open discourse. So I don't know if I know of any particular training that, you know, or cultural understanding training in particular, but I think just opening the conversation is what I would say. And I think that the other thing I want to bring to this group, which, you know, may be a tactic for you all, is if you have heard of Trabian Shorters. He is an asset framing person, and I encourage you to listen to his video. But one way to think about it is, what is your organization trying to accomplish? What are the assets you all have to do that? And I bet you one of the goals is to deliver care, quality care to everybody that meets their needs. And if that's your goal, what does that mean you have to do? So I think that's another way of thinking about it.
Thank you so we are coming to an end of our session today. Kimi, if you could advance to the next slide, I want to highlight a few resources and upcoming webinars. So here you'll see the National Council for Mental Wellbeing, a few events that they have. You will receive this slide deck with these links to register if you're interested. So just want to highlight those there. Next slide, please. There are also some resources that we have here that will be included on the next tip sheet that comes out related to population health management, social determinants of health. And then there's also some information here regarding a health equity office hour and an advancing health equity toolkit. And I think someone is sharing resources in the chat as well. So thank you so much for that. That's amazing. Next slide, please. And then I also want to bring to your attention an upcoming PCDC event. If you are interested in digging deeper into this conversation and examining the impact of racism on sexual and reproductive health, I really encourage you to join us on June 28th. Our session is from 12:30 to 2 o'clock p.m. Eastern time. We have two great speakers that will kind of walk you through what racism looks like and the impact that it's had overall, like I said, on sexual and reproductive health. So definitely a critical conversation and a deep dive that builds off of the conversation that we've had today. So again, the registration link is here. It's on all of our socials and also our website if you're interested in registering and attending. Next slide, please. And then finally, my contact information. If you have any questions or if you need anything, please reach out to me. My email address is here. Again, my name is Shannon Lee, and I just appreciate all of the conversation that we had today. So Eli, you guys have been amazing. It's been a pleasure to work with you. And I think we are right almost at time. So thank you all for your input, your questions. And if you think of anything else that you have, just reach out via email. Thank you so much, Felicia Marie. This has been amazing.